On this podcast, you're going to learn a ton in a very short period of time. I'm joined by my good friend, Dr. Karan Rajan, and he is known as social media's go-to doctor for health hacks. We're going to talk about how to take the best dump of your life, basically. We're going to talk about what over-the-counter medications work the fastest if you want to reduce pain, what you should take instead of a probiotic if you've been prescribed antibiotics. We're going to talk all about why you should take either a 20 or a 90-minute nap and not in between, and a whole lot more. So let me introduce my guest this week. Dr. Karan Rajan is an NHS surgeon and one of the biggest health and science creators on social media. He has amassed over 7 million followers across the platforms with his refreshing, frank, medical myth-busting, and health advice videos. He is the author of the new best-selling book, This Book May Save Your Life, which is a #1 Sunday Times bestseller. Dr. Rajan is a fountain of amazing and very actionable information. These tips may save your life. They can definitely change your life, and they are very simple and easy to incorporate into your lifestyle. How did you become social media's go-to doctor for health hacks? Giving these health hacks, you're debunking health information, and you've got millions and millions of followers. Hopefully at the end of this next 20 to 30 minutes, you're going to find that your brain has exploded with great information. The idea is that you are distracting your nerves a bit. Eggplant deformity of the penis.
Imagine someone's penis looked like that.
You serious?
If your genitalia looks like that.
So staying with the penis does create lines, but though because the actual color
actually have been supplementing
medicine and really of looking at masters in medical aesthetics. It only takes 2 minutes a day, and So let's get started with my interview with Dr. Karan Rajan. Thank you so much for joining me, Karan.
Thanks so much for having me, Tony.
All right. So how did you become social media's go-to doctor for health hacks? It seems like I had not heard your name before. And then next thing I know, you're all over TikTok, you're all over Instagram, and you are giving these health hacks, you're debunking health information, and you've got millions and millions of followers. How did this come about for you?
It wasn't in the script, Tony, and it just came about because I saw so many people making nonsense medical videos online. And the final straw that broke the camel's back was when I saw a patient of mine in real life telling me a piece of medical misinformation about their medical condition, which they'd heard online. And I thought, okay, that's crazy. This patient had diverticulitis, an inflammation of the colon because of diverticular disease, which is quite common after a certain age group. And they told me that they heard online that because of their diverticular disease, they couldn't have nuts and seeds in their diet because the nuts and seeds would get trapped in the small diverticular pockets and cause further irritation. And I thought the reason why people get diverticular disease is because of constipation and a chronic fiber deficiency. And nuts and seeds are forms of fiber. So you shouldn't avoid them. And so I thought, okay, let me look into this stuff online. And yeah, that's the tip of the iceberg. There's so much misinformation. I thought, let me do some debunking or correcting. And here we are.
So you've got this new best-selling book. It's called This Book May Save Your Life. I have read the book. It's just filled with a ton of great information. It is a #1 Sunday Times bestseller. I need to let you all know that Dr. Rajan has joined us from over the Atlantic. You're practicing out in the UK, and he was kind enough to join us for this podcast. So I've taken from his book some of the most fascinating health hacks and facts I thought you as my audience would really enjoy, because I think of all the podcasts that we are going to do, this is going to be the one that gives you the most practical information where you can change your life literally by following these things that we're going to talk about over the next 20 or 30 minutes. So we're going to go through each one of these. We're not going to spend a ton of time with each one, but we're going to spend enough time so that you get the information that you need. And hopefully at the end of this next 20 to 30 minutes, you're going to find your brain has exploded with great information. So the first question, and this is something that I think applies to all of us. How do you take the best dump of your life?
Yeah, it's the million dollar question, and everyone wants to have a good dump, right? Start off the day well. I think, realistically, it's not an instant fix, but it is a small change which can have a massive impact over a period of time. If you keep doing this on a daily basis over a number of weeks and months, this will work. So essentially, there are a number of easy things to apply. First of all, I want to start with the anatomy, which directly relates to your poop dynamics, basically. And a lot of that is to do with the pelvic floor muscles. The pelvic floor muscles are a bunch of muscles which control how easily that you can poop. It stops you being incontinent by closing and tightening up, and it relaxes when you need to go. So when you're just sitting on a chair, like I'm sitting on a chair now, you're sitting on a chair now, your pelvic floor muscles are contracted and they're squeezing down on the rectum. One particular muscle called the puborectalis is like a sling on the rectum and chokes it like a kink in a hose pipe, which stops you, shitting all over yourself at the moment, which is what we want. Now, when you sit in a toilet, like a Western style toilet like this, your pelvic floor muscles aren't actually as relaxed as they need to be. So you could be unnecessarily straining to get beyond that kink in the hose pipe caused by the puborectalis muscle. So if you somehow find a way to relax the puborectalis muscle, you get a straight shot of poop down the rectum. It straightens out the rectum. And you can do that by either raising your knees up so they become slightly higher than your hips. You can do that either by having a small poop stool or rolling up like an old towel and putting your feet on it, or you can lean forward slightly. These two movements relax the puborectalis, relax the kink on the rectum, straightens the rectum, allowing you to strain less and have an easier bowel motion.
So are you a fan of the squatty potty? Because this essentially does the same thing, doesn't it?
Yeah, a squatty potty does do the same thing. And I think the squatty potty, its intentions are great. The problem is it's a fixed size. So for people who've got maybe hip issues, knee issues, getting that elevation by putting a stool, which is maybe like a foot or half a foot tall, can be difficult. That's why I suggest as an alternative, you can use maybe like an old towel, which is just a few inches. Even a few inches is enough to give you that extra benefit.
Does it help to have then a toilet that's a little closer to the ground potentially? Because I know I've been on some toilets, like there's some public toilets, I swear to God, they're so high. And then others that I've been, let's say, visiting people's houses and the toilet is super, super low to the ground. Is there a benefit then to the super low one? Essentially, instead of bringing your feet up, you bring the ground up?
Yeah, the mechanics of a super low toilet is in your favor because you can make that adjustment in your own biomechanics to compensate for that, change in position. So European toilets on the whole tend to be slightly lower to the ground. So yeah, absolutely. I mean, not everyone can use a hole in the ground toilet as we do in Asia or Africa. But yeah, I think a lower toilet is the compromise.
Why should you never hold in a fart?
Now, you probably won't find any published medical literature on this because scientists have better things to do with their time. But if we go back to, basics and, just kind of chemistry, anatomy, when you have a fart is basically various vapors. It's a combination of various gases. And gases do what gases do. They can dissolve and diffuse across tissues. So when you hold in a fart, instead of going out through your anal sphincters, if it remains in one space too long, it has to disperse somehow and it can dissolve across the thin lining of the gut lining. And obviously the gut lining is very vascular, very rich in its blood supply. And these gases, the fart fumes, are dissolved into that blood, which is taken away. And all blood eventually has to go by the lungs, the respiratory system, where gas exchange occurs. The waste products are removed and oxygen is put in. So as part of the carbon dioxide also being exhaled out, these fart fumes in the bloodstream at some point in time will also be exhaled out. So you could literally breathe out some of those gases from your fart that's dissolved into your bloodstream. So we often find in many cases, patients who are chronically constipated and who have stomach issues may also have foul-smelling breath because of the result of chronic, constipation, fart holding, all of these things.
So let out your gas, otherwise it may come out of your breath. That's good advice because nobody wants breath that smells like that.
No.
Okay, so what type of over-the-counter pain medication works quickest? Should you go with gel caps, maybe a liquid, tablets? Is there a difference on the type of pain medication, the not the actual medication, but what form it comes in? Is there a better form than another?
So I think, the main concern a lot of people have is about branded versus non-branded. And I would say in terms of that, there is no difference really, no significant difference in efficacy or speed of action. When it comes to the different types of way in which it's created versus the enteric coated, liquid, etc. Liquid naturally can be dissolved and absorbed faster into your bloodstream. Sometimes the specific coatings can mean that they're dissolved in a certain parts of your GI tract, like the small intestine and different parts. And sometimes the medication, if it's not protected by a coating, it can be destroyed in part by the stomach acid. So it really depends on the type of painkiller you're using. But on the whole, I would say, as prescribed and directed by your doctor and with a meal ideally. But there's not a huge amount of difference as long as you're taking it the right way.
Now, you have in your book some mind tricks to help manage pain. And this is a way to help hopefully prevent or limit the amount of use of pain medications that you take, which, with the issues that we have with the opioid epidemic, what are some good tricks that you can use for your mind to help reduce the sensation of pain?
So if you think about pain and how we process pain, essentially it is, although we can feel pain if we cause a scratch or some sort of tissue damage or cellular damage, that pain sensation is basically electrical signals interpreted by our brain. So that's why if someone punches me in the face and someone punches you in the face at exactly the same amount of force used for both of us, we might both experience that pain differently. I might experience more pain than you because of my past experiences and how I interpret that pain and all the other sensations and inputs I get. So when you're receiving an injection, for example, you're not just actually just getting the injection and that physical trauma. You're also seeing the needle with your eyes. Maybe your past experiences of needles may also influence your perception of pain. So you get all of these various data points which influence or dial up or dial down your pain perception. So actually, if you look away from the time where you're maybe receiving an injection, you're depriving your brain of some of the signals that help it to process pain. So I'm no longer giving it visual input. So that can help to dial down your perception of pain. There's some limited studies suggesting that if you distract yourself with something else at the same time, this is the kind of the gate theory of pain. So if I rub the area where I've had the injection, that actually that vibratory stimuli that I get for rubbing myself can sometimes counteract that pain sensation from the needle. There's also some limited studies suggesting using obscene or offensive language, like if you swear when you get hurt, like, you step on a bit of Lego at 3 a.m. and you swear, that swearing can also help to dull the sensation of pain. So these are a few very basic things, just manipulating your brain that you can use to dial down the perception of pain.
And I totally agree. In our office, we do a lot of injections for Botox and filler. And one of the things that you can do that's very simple is we've got this little vibrating, it almost looks like a pen, and you put it up against the skin, kind of close to where you're injecting. And it really does help to kind of take some of that sting away, because the idea is that you are distracting your nerves a bit and they're getting a little overloaded with nerve impulses. And so it just kind of helps to, like I said, I think feel like distract yourself from feeling that discomfort. And then when my children, this is something that I've known for a long time. So when my children were young and they were getting shots, oftentimes I'd, let's say, if they're getting in their one thigh, would rub the other thigh so that to kind of confuse those nerves and make it hurt a little bit less. I do think that there definitely is truth there.
Yeah, absolutely.
Okay, so one of the things that I do a lot, and my employees will attest to this, that they come into my office and I've got 3 things going on at one time, and they're talking to me, and I don't stop what I'm doing, so I can multitask and get a lot done at one time. In your book, you say that multitasking may not be the best idea. Why is that?
Yeah, I mean, obviously, we're both surgeons, and over the years, we've dealt with various hairy situations in the middle of an operation, and we know that the effect that some distracting stimuli can have on our concentration when maybe things are a bit tricky, whether it's someone talking or whether it's someone trying to get your attention, we know that at that moment of dealing with the patient's life, we have pure focus on that one thing. Now, that's an extreme example due to the kind of occupational hazard of our job, specifically as surgeons, but also in day-to-day life. Say someone's watching TV, someone's watching something on Netflix. You often find, and I've done this myself, I'm guilty of this myself, I'll also be on my phone scrolling through social media or my emails or texting someone, but also pretending almost to watch TV. I'm not focusing on the texting, and sometimes I might text the wrong person, or I'm also not paying attention to the TV. So what happens is when we split our focus, the error rate in our brain actually goes up. So neither task gets completed efficiently, and you end up losing and not saving time in the long run, and your productivity goes down because you're trying to be more productive by splitting your focus, doing more things, but it has the opposite effect of what you're trying to achieve. Our brains cannot focus on more than one thing perfectly.
When you're in the operating room, one of the things that we do is we listen to music, and there's often discussion. How's it like in your OR? Where I trained, my plastic surgeon in Beverly Hills, who I trained with, he had no music. He had very little talk, and the entire time he was focused on surgery, which when you're doing 6 or 8 hours of surgery in a day with no music at all, and all you're hearing is a beep, beep, beep of the anesthesia machine, that can make a very long day. What's it like in your OR, Karan?
Yeah, I mean, over the years, I've worked with a number of surgeons who, sometimes no music, no talking. Sometimes surgeons like really loud music. In my own preference, when things are going smoothly, it's an elective surgery, so planned surgery, I might have some music on. And when things are controlled, if it's emergency surgery and things are, kind of fueled and a bit rushed and a bit, tense, probably won't have music. And if I do, it will be very low to the point where it's kind of almost in the background. You can barely hear it. So I think I change according to the situation. But if I had a preference, I would try and get music that is without lyrics. Because I've often found myself, if I hear lyrics when I'm revising or doing surgery, I'm almost distracted by the lyrics where I kind of trying to think about the lyrics. But if it's just background music without lyrics, I don't think about it and I focus on the task at hand.
That actually correlates with, there was a study that looked at music playing in the OR and the how well the surgeons performed the operation. And the actual study showed that if surgeons were listening to classical music, it appeared to increase their dexterity and the efficiency at which they operated. However, that wasn't necessarily the case for music other than classical music. And for me, I'm kind of like you. The music itself is usually secondary, but it's always playing in my room. But it's always stuff that is at a certain a volume level that, my belief, it's not distracting for any of the members of the OR. And if it is, then we turn it down even lower. But you and I have, I've been in operating rooms where they're playing like AC/DC super loud. It seems like those are usually like the orthopedic surgeons' operating rooms where it's just like heavy metal, hard rock, like playing really, really loud gangster rap. And I don't know how people operate when music is that loud. To me, I find that it does get distracting when you get up to a certain level.
Yeah, no, I totally agree. I mean, like yourself, I work with surgeons who are playing hardcore drum and bass, and it's just a different vibe and quite scary, actually.
So you're a surgeon that does a lot of GI type related surgery, yet you don't recommend taking a probiotic if you're prescribed antibiotics. So what do you recommend instead?
Yeah, so I would say that for the average person who's on antibiotics, which is pretty common these days, taking a over-the-counter probiotic supplement is unlikely to do you any favors. Medical grade probiotics, so suppose you're on long-term antibiotics, if you've got an infection that needs several weeks of antibiotics, or you're immunosuppressed and you're prescribed antibiotics for several weeks or months, having medical grade probiotics directed by your microbiologist, by your physician, there may be some role in specific cases. However, the easiest thing to do to get live microbes, which are probiotics, is actually through your diet, dietary manipulation. So things like kefir, kombucha, pickled vegetables, pickled fruits, those sort of foods which contain a high volume, which are fermented, contain a high volume of live bacteria and microbes, is cheaper and it's easier to implement in day-to-day life and carries more benefits than just saying, oh, we're getting these microbes. You know, you're getting antioxidants and you're getting fibers and you're getting like the whole package in one, essentially. And what I would say is, you know, if you are taking antibiotics, you should actually question how long you need to take it for and make sure you don't prescribe it yourself. Because if you think you've got a cold and, you know, it's probably just a virus, you should think again, because viruses don't need antibiotics.
One thing that I was dealing with about a year and a half ago were severe eye floaters. And I'll tell my story after this. But one of the things that you put in your book is when somebody should be concerned with eye floaters. In general, eye floaters are not considered anything to be all that serious. Everybody has them to an extent. But when should you be concerned with eye floaters?
Yeah, so I think like and everyone's experienced eye floaters, and it's the kind of known to be hypothesis, which most people agree with. It's like a bit of collagen detached and just floating in the eyes, and maybe some, you know, dust in the back of your eye as well. And if you suddenly experience a huge increase in the number of eye floaters or the frequency to the point where it's actually, you know, like a fireworks display in your field of view, then that could be a sign of something like retinal detachment, where your retina is actually, you know, possibly because of trauma or something like that, physical eye trauma, the retina is being detached from the back of your eye. So that is a medical emergency. That's one of the few eye emergencies that exist and gets ophthalmologists all hot and bothered. So yeah, if you notice a sudden change from your baseline, and this goes for most things, you should seek an emergent opinion straight away.
So I was in Salt Lake City and I just finished a conference. My uncle is an optometrist, and for years he told me, because I always had really I was nearsighted, and I think I was like a -7 diopter at one point. I ended up having LASIK done many years ago, and it was honestly the best thing I ever did for myself. But he always told me, he said, Tony, you know, if you get a severe increase in eye floaters, call me right away, because of the shape of your eyeball. The reason why you're so nearsighted was that your eyeball is kind of like oval shaped, and you're going to have a higher risk of a retinal detachment. So just what you said, he told me this years ago, and I was in Salt Lake City a couple of years ago, and I woke up the morning we were supposed to leave, and one eye, it was literally like a snowstorm of floaters. Like I could barely see through the eye. It just happened very, very suddenly when I woke up. And it was very marked, like literally like you're looking through a snowstorm. And so I got back home, and I have a friend of mine who's an ophthalmologist, and I told her, hey, this is what's going on. And she said, I'm going to call a retinal specialist. You got to see him immediately. So I go see the retinal specialist the next morning. It's a fellow. This is Sunday now that I see the retinal specialist in the basement of this building at the local hospital. And he numbs up my eye. He uses all these instruments and takes a look at it. And he's like, you've got a retinal tear. You've got a tear in your retina. And he goes, I think you've got two. So I said, well, how do we fix it? And he goes, we can laser it because it's early enough. And so he's lasering this. We're doing this as a fellow. So this is not an attending surgeon. It's a fellow, meaning that they're in training to become a retinal specialist. And he says, I fixed one of them. And this is like excruciating. Even though your eye is numbed up, it's excruciating. And he says, there's another one down there. And he goes, I think I need to do cryotherapy to treat that. So I'm like, okay. And he goes, let me go get my stuff and I'll be back in a minute. So I go, Karan, I go on my phone. I start looking up cryotherapy for the eye. And I'm like horrified at what I'm finding. Like he's got to take a needle and put a needle in my eyeball to numb up my eyeball. And then you do this, you basically freeze it. And afterwards it looks like your eye, you've been punched in the face, and it's like horribly painful and all this stuff. And we're in the basement on a Sunday of the hospital, nobody around. So he comes back to see me and he's like, are you ready to get it done? And I'm like, well, what do you think about waiting till tomorrow when your attendings are around and you've actually got support staff here? And he's like, thinks about it. He goes, yeah, maybe that's a good idea. Let's wait till tomorrow. I'm like, oh, thank God.
Oh my God.
And so the next day I go
Wow.
and the whole place is filled up with doctors and nurses and MAs and everything. And they dilate my eye, they numb it up again, they take a look at it. And the attending surgeon, who's probably 60 years old, he's been doing this for a long time, looks at my eye and he's like, yeah, you don't need cryotherapy. It looks fine. You only have the one tear. And I was like, oh my God, thank God. So if you get a sudden increase in eye floaters like I did, you got to get it checked out, because the worry basically is that if it's early, if they catch it early, like they did with me, they can use a laser and treat it and you're done. If, however, you actually get a retinal detachment, which happens after that, that's kind of the next step, then you got to go to surgery. And that's a whole other deal that you don't want to deal with. So that's
you
why
can
you
lose
should
your
be
vision,
concerned. Yeah, with an increase in eye floaters. And worst case scenario, the surgery doesn't work, you can lose your vision from it. Okay, so shifting gears, why should you never pluck your nose hairs?
Yeah, and again, I'll put my hands up. I've been guilty of this. I'm sure many people have. Your nose hairs, you've got two different types of nose hairs. The ones that you obviously see, that's just dangling there, that's tempting you just to rip it out, they're called vibrissae. And even these vibrissae, they act as physical barriers, as air filters, before the air from the outside gets inside that delicate, moist internal respiratory system. So they do have a role in making sure that dust and any larger microbial particles don't go inside. And when you pluck them, you deprive your own air filtering system, number one. So you allow more of the crap from the outside into the internal environment, which can cause irritation and allergies, etc. But number two, when you rip and root out that little noseweed, what you do is you leave behind a micro abrasion, like a small little nick in the skin, and theoretically leaving that small, orifice for microbes to creep into. That area around the nose, it's technically in that region we know, as doctors, as the triangle of doom, the triangle of danger, where essentially behind your nose in that triangle that you see here is the cavernous sinus. And that area is very closely connected to the drainage system, the venous drainage system, to the brain. And if you get an infection of your cavernous sinus, in rare cases, that could lead to something known as a cavernous sinus thrombosis, a clot in that drainage system. And down the line, that could form abscesses, infections, seizures, that's not common. So if someone picks their nose and plucks their nose every day for the next 10 days, they may be absolutely fine. And chances are they will be absolutely fine. But the chances of what I've described is not zero. So why pluck it when you can just trim it or just take some scissors to it or whatever? It's a much easier thing to do than rooting it from, its kind of base where it's attached.
Why, if you're eating something spicy, should you not drink water to reduce the spiciness? Because this is something that growing up, I'm Korean American and we ate a lot of spicy food growing up, and I'd be drinking a lot of water. And in your book, you said that's not necessarily all that helpful.
Yeah, similarly, growing up in an Asian household, Indian household, a lot of spicy foods, and I've learned the lesson the hard way. And when you eat something spicy, the main spicy chemical is capsaicin. And capsaicin can bind to receptors all throughout the body, from your bum to your mouth to your skin. And that's not easily washed away with just water. And you need the milk proteins in dairy, so milk, yogurts, ice cream even, that has a better ability to actually wash away the capsaicin and bind to it and get rid of it than just water. Because water just kind of washes it around there. It doesn't actually get it away. But you can think about it as like, the dairy products like milk is like the detergent to wipe away the stain rather than just using water to wash it away. So that's what my advice would be.
Difference between trying to dilute it versus actually neutralizing it, essentially.
Exactly, yeah.
All right. What about, now we're going to shift gears completely here, and we're going to shift gears and go down low. But what is an eggplant deformity of the penis? It sounds absolutely horrifying. I know myself, I do not want an eggplant deformity of my penis, but what truly is an eggplant deformity of the penis?
Yeah, so I think actually the definition of this was changed for the American audiences. So you guys call it eggplant, we call it aubergine, same thing. The eggplant vegetable, it's big, it's purple, and it's got like a bean-like shape. Imagine that looked like imagine someone's penis looked like that.
Are you serious?
You wouldn't want it to look like that. And the reason it
I
looks
think
like
Dr.
that,
Ricky Brown, I think he has that, but go on. Sorry.
I agree. Essentially, if your genitalia looks like that, something's gone wrong. And in this case, the most likely diagnosis is a penile fracture. And you might be thinking, how can a penis fracture? It doesn't have any bones. It doesn't. You'd be absolutely right in thinking that. But there's a fibrous, thin layer of tissue which surrounds the main structures, the main cylinders, which are involved with erection. And it's called the tunica albuginea, literally a tunic or a shirt around the main penile structures. And this can tear with excessive bending and curvature. And if it tears, the blood from the inside, which it's holding in, is released. And you get a lot of this bruising and hence the kind of black and blue appearance and deformed appearance of the male member.
So that's essentially the penis fracture that people hear about that Dr. Ricky Brown had. Just kidding. Okay, so staying with the penis, one of the things that I do, and we tell the kids to do all the time, before we go on a trip or before we go to a concert or a movie, we stop and do a just in case pee. You pee just in case you need to go so that you don't have to go throughout, let's say, the movie or the event. You say in your book that maybe that's not the best idea. And why is that?
So I think in the case you described, like going on road trips and stuff, I think it is fine to go on just see if you need the toilet before you go on the road trip. I think that's like a sensible idea because it stops you holding in your pee for a long period of time, which is arguably worse. But I think a lot of people get into the habit sometimes of peeing frequently and peeing small amounts frequently. And they just kind of feel they need to go, even if it's like 20 mils or 30 mils or 50 mils. The thing is, our bladders are designed to relax their sphincters and let loose the urine once it reaches a certain degree of stretch. Just like our rectums, our bladders have stretch receptors. And once the stretch threshold is released and that signal is released, a sensation is sent to the brain and the brain says, okay, we've reached the amount. I'm going to send a signal back to release the sphincters and relax the sphincters, and then you go pee. If you ignore that stretch signal and you try and force the pee, you're actually trying to force the pee against a closed urethral sphincter. So you're forcing it across there and you start to become desensitized to your natural stretch reflex. And over time, you weaken your pelvic floor muscles and you actually develop some degree of urge incontinence where actually even the smallest amount of urine can trigger the need for you to go. So you get this unnecessary frequency where you're just going all the time. And you can recover from that with bladder and pelvic floor training and physiotherapy. But that's why you should not do the just in case pee unnecessarily. Once in a while, it's fine, but unnecessarily, it's not a good idea.
Okay, so I think what I'm doing is healthy, but yes, it's when you are constantly every 20 minutes going to pee because you're starting to feel a little bit of an urge, then that can become a bit of a habit, and that can actually then impact how the muscles of your bladder react and make you have more issues later on because you now can't hold it for long periods of time.
Oh, yeah.
Makes sense. So I am a napper, and one of the things that I love to do on the weekends is I'll eat lunch and then I will take a nap with my dogs. Now, when I take a nap, it's, when my kids were young, the naps would be sometimes like an hour and a half long when we were sleep deprived. And you may remember in residency, same with me, we'd take a nap in residency, and it doesn't matter if you're post-call, pre-call, whatever, those naps can go a long time. Now I find that 15, 20 minutes is all I really need to get myself kind of recharged up a bit and get rid of kind of those sleepies, those afternoon sleepies. In your book, you say that the ideal length of a nap is either 20 minutes or 90 minutes. So why is it that you should do either 20 or 90-minute naps and not somewhere in between?
Yeah, I mean, I would say it's not an exact science. I mean, we all have our own circadian clocks and our different anatomy and wired different ways. But generally speaking, 90 minutes constitutes a full sleep cycle. And 20 minutes would be part of the sleep cycle. That's the lightest stages of sleep. So you're not in the deeper stage 3s and 4s of the sleep. So if you sleep for 20 minutes and then you wake up after 20 minutes, you are awakening from a lighter sleep. So you don't feel that grogginess that you would had you awoken from the depths of your slumber. So 20 minutes for that reason is okay. 90 minutes has been proven in the literature to actually improve memory retention of anything, any tasks, procedural or mental you were doing before the nap. Because at 90 minutes allows for greater consolidation of anything you've been learning, because it's a full sleep cycle where you get the non-REM and REM stages. But if you sleep significantly over 90 minutes, you don't know which part of the cycle you might wake up in. So you might wake up from a deeper stage and then you'd feel really groggy and you get that sleep inertia, which is that groggy feeling. So 20 or 90 is a pretty good target usually.
And that makes a lot of sense, because I do find that if I sleep more than that 15, 20 minutes, and let's say I sleep 45 minutes to an hour, oftentimes I wake up and I'm disoriented and it's like, what day is it? Where am I? But the 20 minutes, usually I wake up and it's like, okay, like, oh, I just had a nap. It's perfect.
Yeah, exactly.
All right. So last thing I want to ask, and I think this is also super helpful, although right now it's the summer, which is great, and people aren't in general quite as sick as we are in the winter, maybe fall months, but you've got some tips, some very practical tips to boost your immune system in your book. Can you let us know a couple of these?
Yeah. So I would say some of the most underrated ways to kind of, I say quote unquote, boost your immune system, or at least optimize it and make sure it's not kind of degrading, is actually just sleep. Again, there's a study which suggested that even just one night of sleep deprivation can lower your immune system's natural killer cells by 40%. I know these are cells which can get rid of viruses, early cancers, bacterial infections. They're pretty important. And we know that chronic sleep deprivation weakens the immune system. I certainly know when I'm finishing a run of night shifts, I often get a cold immediately after or during my night shifts because my sleep is completely out of sync. And so I would say this is the number one thing to kind of boost your immune system. And also the other kind of easy thing I would suggest is actually increasing your diversity and intake of plant-based content, because it's from the plant-based content, so colored fruit and vegetables like the aubergine or the eggplant even, is where you get your antioxidants. And antioxidants help to fight all of those free radicals and actually help to complement your immune system, get rid of any threats, harmful DNA mutations and things like that. So I think those two things are kind of easy, actionable things that anyone can incorporate into their lives.
Well, this has been super, super interesting. I'm with Dr. Karan Rajan. He is one of social media's most well-known physicians. He's got millions of followers across all the platforms. I strongly encourage you, if you don't follow him, definitely follow him. He has a new book called This Book May Save Your Life. I've read it. It's filled with just a ton of fascinating information. And, there are a lot of doctor books out there that are honestly written kind of dry, and they're hard to get through. And this one that is exactly the opposite. If you've ever watched Dr. Karan Rajan on social media, he's got a lot of kind of these witty little sayings, and he speaks in a very intelligent, but I guess there's like these humorous little things and sayings that and creative ways to put things that I don't know of anybody else that speaks that way. And the book is written in that way. So you can literally, as I read the book, I could literally listen to your voice saying all these words. So it was just so well done and so entertaining and so just information packed. I want to congratulate you on writing such a fantastic book.
Thanks so much, Sonny. It is so much.
It is on sale everywhere books are sold. It's a #1 Sunday Times bestseller. And I want to really thank you for joining me today.
No, thanks for having me. It's been fun.
So if you've been enjoying this podcast, if you can leave a rating or review on iTunes or Spotify, it definitely helps me spread the word. Otherwise, I will see you next week. My name is Dr. Anthony Youn, and this is the Dr. Youn Show. Thank you so much, everybody, for watching and for listening. And we will see you next time. As always, remember to eat real food, use clean skincare, and auto-juvenate before you operate.